All right. Good morning and welcome to Friday Chalk Talk. Today's episode is on total pain, and we are very lucky to be joined today by Chandra Farrell. She is the sole NP provider of palliative care at Trinity Hospital in Chicago, and she recently finished her DNP during COVID. Our format for today is going to be a presentation with a little sprinkle of discussion throughout. So sit back and enjoy. And Chandra, I will hand the mic over to you.
Thank you. Thank you. Thank you. So good morning. And thank you guys for making time in your day to discuss total pain with me today. This is a topic of interest to me because for many years in nursing, before becoming a nurse practitioner, I feel like I saw the signs of total pain, but didn't know what to call it. You know, it felt, I remember even as a young nurse trying to explain to a doctor that no matter how much pain meds I gave a person, it just wasn't enough. And, you know, sometimes it became, oh, well, they must be drug seeking and things like that. And you know, we just didn't have an answer for why the meds weren't working. And I started doing the things that I thought could help. You know, let's call the chaplain. Let's get your family to visit. Let's try to fix the things that we can fix. And then when I, found out about total pain, the light bulb went off and it said, okay, so not only is there a name for it, but there's a fix for it. And so Dame Cicely Saunders, if you are in palliative care and hospice, of course, you know her name, you know her face. She studied politics, philosophy, and economics. She then went into nursing. She became a social worker. She also became a doctor. I mean, I thought I was busy, and then she became the founder of the modern hospice movement, which eventually led to the establishment of palliative care. One of the things I thought was most interesting when I was researching her is that much of our current pain and symptom management is based on her research and kind of her personal calling to make sure that we don't handle pain the way they were handling pain before she kind of, took it over. There was a statement she made that I thought was really interesting, and it was that pain there is no intractable pain, there are intractable doctors. And so what that said to me is that if we tried, then even if it's not the physical pain that was being treated, then there's a different kind of pain that we can look into to try to help every patient. So what is pain? Pain has been defined in many ways. It's an unpleasant sensation that ranges from mild, localized discomfort to full-on agony. Most of us know what agony is, but the truth of the matter is that agony is different for every person, the same way pain is. Pain, as we know, has both physical and emotional components based on what the pain is originating from. And the word pain originates in the Latin from the word pena, with meaning a fine or penalty. I thought that was specifically interesting because there are many people, especially in the frame of total pain, where we will talk about that, in a couple of slides, where is this a pain that is a punishment for something? Did I somehow earn this or deserve this? So we'll get to that in a minute. So what is total pain? That's pain. This is total pain. So total pain is a concept that accepts that serious illness disrupts one's expectations of our future. Total pain recognizes the holistic experience of pain and the interrelational nature between physical, psychological, social, and spiritual aspects of a person's life. And it's interactive, as you can see by the graphic. Nothing on the photo stops at itself. Everything touches something else. If you're in psychological pain, you're most likely going to also have some social pain. because the people around you are going to be affected by the pain that you are having. So it affects you socially if emotionally and mentally your pain is so great that you can't go to family events, or you're blocking everybody out. You can no longer talk or be invested the way you used to be. So everything is interactive. There are no places where one thing sits alone. And then I love that the way she built the concept, it always considered the family and friends. It considers not only their pain and their issues and how they may be affected by the person's illness, but it also considers how treating the patient's total pain also helps the people who have to care for them. So I found in the research this drawing that she created while she was working with specific patients. And on this particular slide, you can see that she was seeing just a variety of different symptoms that she divided on here between body and mind. And what she believed was that when spiritual issues are addressed, patients require less pain control. And so if we look on top and we just pick out a few, and if somebody wants to jump in and name one that you think is very interesting that is on there, I listed a few here. So for body, nausea, pain, weariness, asphyxia, I saw breathlessness, pleural effusions. Down at the bottom for mind, I thought it was interesting that weariness is also down in the mind part. It was the one thing that I saw that was in both places, which means that we can be both weary in our minds and in our bodies. And so, of course, if you think about weariness, then it makes sense that it lists also loss of hope, loss of independence, being lonely, being fearful. There is over in the corner where it says resentment and paranoia. There's also where it says that there's some feelings towards God. That's where that spiritual piece comes in, and so these are things that I thought was very interesting, the way as she dealt with these people on a very deep level, she was able to find all these common pieces and then break them up into things that make sense. Because if they are things that make sense, then you can start working towards solutions, as opposed to just random symptoms that don't mean anything. She pulled them together in a way that says that if we pay attention and if we notice them, then we can help fix them. Did anybody see anything that stuck out here on this list for you? It may be a little difficult to see, but I thought this was a really great picture of how she pulled this together.
I love that she put hope on here. And I think hope is so imperative as we talk to a lot of our patients, because hope can mean so many different things to so many people.
So I wanted to include just a brief conversation. It's probably an entirely separate chalk talk, but I wanted to talk about how pain and suffering are indeed different. And so we won't get into what makes them specifically different, but what I want to talk about is how pain, we know that originates in the brain, and suffering is not found in sensations and pain. It's not found in our emotions and fear. Suffering, in most of the research that I did, was described as being our whole mind. It's a state of being, as opposed to originating in a specific place in our bodies. And so that being said, I have found in my practice, not just in my palliative care program, but in my entire 24 years of nursing, that there are some people, which makes it harder sometimes for us to do our job, or at least we perceive it as harder. As long as you think it's a barrier, then it's hard for you. But when you really dig into why they are accepting of their pain or suffering, it can help you better help them. And so I have seen some people say, I earned this pain, I deserve this pain, there's purpose in this pain, or, I'll be rewarded for it. And it's difficult for many providers to accept that there is a pain that a patient won't let you touch, whether it's physical, emotional, spiritual, etc. Has anybody else had patients who have said one of these things? And if so, if you'd like, can you briefly share with us, the context and how you helped that patient?
I was going to answer, Chandra, and then you put that last part in. That's a lot more challenging. The answer to the first question is, I would say about once a week or once a month in my career in hospice and palliative medicine, that yes, I don't want you treating this pain because this is going to give me salvation, or it's going to some other higher purpose, as you put on the slide. I think to be tried, and in the time we have, the tougher question is, how do I respond to it? Is, try to be supportive and not be obviously confrontational. That's not going to get you anywhere, but hopefully by communication and working with them and honoring that perception or whatever that is in that individual, that we'll get to a common ground and be able to, hopefully, as you put the phrase, and I think you put it very well, allow us to together touch that pain.
Thank you for sharing that. Go ahead, Dr. Bell.
Oh, I'm sorry. And someone put in a comment, and I agree, because for me, when I've heard that, it's often been related to their religious or spiritual beliefs. So I try and call in the chaplain or to find out if they're involved with their spiritual advisors.
I have one
And
quick thing to add too.
Yes, go ahead.
I find the difficulty is when this is the patient's belief, but it's not verbalized. And sometimes you have to get to the bottom of that. And that's even more challenging. And I find that that's more common, even that sometimes when they verbalize it, because they don't feel like the medical team wants to be a part of this piece of the puzzle. And so it goes unsaid.
That's true. I recently had a very similar patient who described that, the fact that I sat down and pulled up a chair and I didn't shy away when he immediately started saying that, it's not that he was trying to hold everything up by making no decision. It's just that he was waiting for the Lord to tell him the right thing to do. And while I did, I did what I do, and often we're the ones who slow the team down to give people a chance to catch up. They want them to make these sudden decisions when you just gave them life-changing information. Their life went in that moment that you gave them a diagnosis. It became the time before I had cancer and then the time after. Immediately their lives have changed and they just need a moment. And so in the process of us slowing down what is happening in the hospital setting or in the home setting, I think that we just need to give people room to figure out. And it took me a day or two to move him even a step, further. But at some point I did have to share that, while you are waiting on the Lord, the insurance does not support that as a necessary reason to stay in the hospital. That's not a diagnosis and such. And so he laughed and we were able to joke about it and we talked about it in depth. I asked him for permission to include the chaplain. We just talked about it, and you got to give people reasons to be okay with sharing with you those things. Is there a reason why you won't let us treat this pain? Is there a reason why you seem to be fine being in pain? And I've also had to talk to some physicians and, they'd be very frustrated. It's almost hurtful to us, right? To have a patient who we believe is absolutely suffering. But the truth of the matter is that, suffering, just like pain is whatever a person says it is, so is suffering. And if they do not believe they are suffering because this is purposeful, then you can't treat it with the frustration that you would a person who's just refusing to cut off a gangrenous foot, right? This is not a foot that's killing me. This is a necessary suffering. And it's not suffering because I'm saying so. It's suffering because that's what you keep calling it. So we have to give room for the fact that there are reasons why people might accept a particular pain or suffering. And I just thought it was important to kind of touch that. So we'll talk next about a case study. Many of the details have been altered to protect patient privacy. This is actually a mix of 3 very similar patients. So what I would like to do is have you guys kind of read along, or, you know, speed read, whatever you're good at, and we'll go right through this. And I'm gonna just kind of ask us to talk about what you see, what's physical, what's psychological, which parts are social and spiritual, and in what way would you help this patient if this was who you walked in on day 5 of their hospital admission. So you have an African-American male in his late 80s who has no wife, no children, no siblings, and lives alone. He's Christian, but there's a very distant history of going to church because it's been a while. Metastatic prostate cancer, hospitalized 5 days before you get to meet him. Persistent pain in the low back, groin, and thighs, leading to him ambulating less, and now he's becoming incontinent because he's not able to get up. Denying nausea and vomiting, but still doesn't want food and water, declining any further tests, but also declining hospice. Actually says things like, you know, I have repented of everything I can think of, so why won't God take me? I don't need you to call my church because they probably don't even know me anymore. Having issues of concerns, you know, had a significant pride about the fact that he takes care of his financial responsibilities. You don't need to worry about putting me out of here because I pay my bills. Call the financial service people. And then there are the questions about, well, if I'm dying and I'm alone, then who's going to take care of my property? Who's going to get my money? What's left of me if I'm dying right now? If what you're saying is true, what happens to everything I've built? You know, what do I leave behind? And so I'm interested in what you guys have to add here.
So when I see the term, how do I help? I like to expand that into not just thinking about how do I help the patient, even though certainly that's a major focus. I think a lot of when suffering is really complicated, I think a big part of our role is to help give that patient a voice in the chart, to help the medical teams also appreciate why they're suffering. So that way there are not misconceptions or assumptions made. And I think that the more that the other teams understand why somebody wants what they want, even if they don't agree with it, understanding that why helps them to be more likely to accept that. So I think that would be one way I would consider the question of how would I help?
Okay, very good.
And I don't know if you mentioned it, I don't see it here. Does he have family involved? Is there anyone who's meaningful in his life?
Not this particular, not among that group. There were very common similarities between the 3 patients that I kind of used as this over like 15 years. And none of them had extended family that, you know, so there were no visitors, no nieces or nephews, no one meaningful, you know. Usually what I have found is when they're worried about who's going to get their property and what's going to happen to their money, it's because they don't have anybody to leave it to that they trust or that they're caring about. You know what I mean? They don't have something else they're connected to that tells them, oh, well, at least I'll leave it to my nieces and my nephews or my grandkids, or, you know what I mean? So these particular patients all have one thing in common, and they didn't have anybody extended family.
It's like an issue about legacy.
What happens to me if I'm also, I forgot my light is on a timer. What happens to me if I'm the only one of me? You know, that's one of those existential questions. You know, who am I? What do I leave behind?
And he had a distant church history. Were you able to delve into that maybe they do remember him or they can reconnect?
that was one of the things that I did offer to every one of those patients. That's actually a part of my common practice is to, and we'll get to that on the next slide, but I call in everybody. So even if you've not been to your church in 15 years, if your name is on the roster from 80 years ago, I will call your pastor and say, you have a church member here. You know, if they allow me, I will bring in your church or faith leader from whatever background, in order to offer you some support. People are generally surprised when they allow us to reach out at how willing faith communities are to surround you, even when you've been absent. But is that not what they're for? You know, they're the ones that, you know, we may not consider them as first responders, but even as faith communities, they're the ones that rush in while other people are rushing out also. When people are in pain, they're the first ones that say, how can I help? One of the other things while we sit and look at this was me asking him, you know, when he kept saying that, you know, why won't God take me? And, you know, I've repented of everything that I could think of, and things of that sort. And, you know, you're declining food, you're declining water, you have this pain. Two of the gentlemen wouldn't even allow the pain to really be treated, because they just felt like there was no more purpose in their life, and that if they left the pain untreated, then they might die faster. They were just hoping to have it all be over. And so what do you do? What do you do when you're asking, at least let me treat the one pain that I can help right now? You don't have to have the physical pain, because maybe we can have a deeper conversation about the other pain if I can break the cycle of the physical pain. You know, I kind of call that quiet and like calming the storm. You know, if you let me calm the storm, then we might be able to focus in on some of the other pieces, you know. Anything else that anybody can find, a place where you might be helpful, useful, something that sticks out or stands out?
I just wanted to comment that 2 of those quotes are related to his faith. So even though it's a very distant history, that seems like that is one of the most important pieces to address here.
What about the fact that he's not nauseous or vomiting, and yet he's declining food and water? How do we address that? Who gets involved to help if that's the issue? Do we just throw psych at him and see if they find him decisional?
I suspect you probably asked him why that was happening, or why he was doing that.
Yeah.
Was it part of the same thing to speed things up?
It was. He felt like the same way there's no reason to reach out to the church because they won't even know me. There was no reason to eat when I'm hoping to not be here very long. And he wasn't looking to use this as a mechanism of suicide. None of these young gentlemen, none of these gentlemen, because 2 were in their 90s, but none of them were trying to use it as a method to purposely harm themselves. They just felt like there was no more purpose in their life. If I'm now terminally ill and I'm as sick as you say I am, and I have no one, but I need to wrap up all my business. So let me pay my bills. Let me pay what I owe people. You know, let me think about what to do with my property. Stop asking me about more tests because I don't want it. I don't really want hospice because I don't want help dying. I just want to die.
You know what, Chandra, I just listened to a presentation about that, and that is a legitimate choice for patients who are in stage disease or progressive neurologic disease, if they
Right.
choose to.
Right. Voluntary cessation of like food and drink.
Mm-hmm.
Mm-hmm.
And it's looked at, you know, medically, legally, ethically, morally. It is a decision you can make for yourself.
Mm-hmm. Mm-hmm. Well, thank you all. So when we kind of think about a patient like that, right? What stuck out in this particular patient was, the social issues where he kind of didn't have anybody. You didn't have children, your spouse has passed away. You're not talking about this extended family. The only extension of yourself you had was this church community at one point. And now, because of whatever reasons you were distant from them, now you feel like they don't exist anymore. But, what I find is that we have to remember that you can't treat total pain alone, right? It's everything about them that hurts. Every single thing about your life hurts. And I'm not afraid to say that. When I'm doing my assessment, when I'm doing a goals of care conversation and I'm asking these questions, I actually really tailor now the way I do my assessments, as I'm having a conversation, to pick out, is this total pain first, as opposed to listening and hearing it, and then it becomes an aha moment later. I look for it at the beginning so I know how to start working with it. And what you realize immediately is that there's a whole person here that requires a whole team. And so you do yourself and the patient a great disjustice. It's an injustice rather when you don't utilize all the people and all of their knowledge and it's also about time management. You could spend 2 hours with them and may not have moved them in any direction. When someone else now has the ability to come in and sit with them and do those things. When I saw this picture, I was thinking I would love some volunteers. I love that specifically with volunteers and spiritual support. The reason I call those people in is because those are not people who are viewed as having any ulterior motive. If you send in the social workers, the care managers, the docs, the NPs, they see the rest of us as working on behalf of the system. And over time, they do build trust with us. We see this all the time in palliative care. But certain disciplines are viewed as non-threatening, they're neutral, especially the chaplains, because it doesn't matter their religious background, they're there for every patient of every faith. And so even when I'm offering the chaplain, I do also invite in your own particular faith leader. And so there's just a lot of value in making sure that we don't forget that. Now, another thing I want to kind of add here is that there is a later version of the total pain concept that went on to include staff. So the same way that it was including friends and family, she started to discover that staff made a big difference in addition to friends and family, because we can also suffer with patients, and that it matters when we treat all the things that hurt about the patient, because it also treats what starts to hurt about us. The other thing is that we have become, when they allow us, we've now become part of that patient's emotional experience. And so I think it's a wonderful concept in that it's not just psychological and social and spiritual and physical, and it doesn't include just the patient, but their friends and their families. And now it's also extended to include staff, because we can't do this job and not have some emotions be involved. So what is the role of palliative care in total pain? I think lifelong learning, when you think about all the pain management, information that's out there, how the research is growing, total pain learning, assessment techniques, critical conversation skills, leaving room for the patient to be, kind of done talking with you today, but willing to talk with you again tomorrow, not taking a no today as a forever no. Sometimes like I mentioned before, we're the person who needs to buy people time to kind of catch up with what we're saying. Again, research, making sure you're looking at, the types of research that's being done, what type of study was it, what was the sample size, who were they asking, what's the value, what's the quality of that research when you compare the one thing to the other. Of course, best practices. One of the things that I saw was that we have not touched on that again here. Some things are just simply a whole other chalk talk. And so we have to consider, acknowledging people's cultural influences, some of a person's existential angst. Again, it comes from who I am, what I've done, what do I leave behind, what has my life meant? But these kind of emotions and ideas, they are based on the cultural and environmental influences that brought them here. And I don't mean brought them here to the hospital, but I mean brought them 90 years into the future in their life. How did they grow to become that person? And those are things that you can't work through in the first hour that you met them, right? And so you bring in all the knowledge and all the best practices and all the teaching that's available for how do you meet a person where they are, collaboration, whether it's your team with all the other teams, whether it's your team and the teams with the family, or your team with their faith community or their community leaders. Every time I have invited faith leaders to a meeting with a family or with a meeting with the patient, they have appreciated it. And they actually almost always ask, do you do these conversations in the community? Is there anywhere we can get more information and more teaching so that we can help the rest of our members? And that's another reason why I invite them, because if they sit there and they're able to help this patient, you'd be amazed how that skill set kicks in and they're now better with their next member who gets into a situation. So don't forget to collaborate. And then advocacy, there's the pain that we can see. And often, you can only, again, address the suffering that they will acknowledge is there. I've had to tell docs before, it's not suffering. It's only suffering if they think they're suffering. It's not suffering if they believe that it's part of what they have to endure to live. And then, of course, teaching and passing it forward. This is what we're doing here, making sure that, as you find out new things or as you discover interesting things, that you don't keep it to yourself and then you just become, this vast book and wealth of knowledge, walking around with it all tucked in, that you pass it forward, teach other people. And then I think the biggest part for me is making sure that we show up. And I don't mean just walk in the room and, we showed up because we were consulted. I showed up within 24 hours like I'm supposed to. But, palliative care is not just consulted as another intervention being ordered. I don't believe that. I sometimes tell my patients that if they want it to be, this is likely the beginning of a two-way patient and trusting medically related human relationship. We are both humans coming to the table. And even though we've met under a medical circumstance, this can be very patient and very trusting, and we can really build on something here. I think that in the interest of reminding ourselves that, there's COVID and there's self-care and, we have to consider ourselves and everything. We have to take the time to make sure that we're not running room to room to room, because if we are faithful in our efforts to ensure that when we walk in, we are our best whole selves, again, not running half empty from one room to the next room because we've poured all out in the last place, then we're more likely to be able to meet the next patient where they are within their whole selves, even if their whole selves is currently broken, right? We have to show up as whole as we can be so that we can meet them as whole as they can be in the moment. And this is the goal. In order to be able to assess total pain, you have to be able to see total pain. So you have to meet people where they are. Well, we've lost them before we even started.
I just, even though I put something in the chat, I just want to say verbally, because I like to talk, Marty, and everybody else knows that. just to reinforce what others have said, this was wonderful. We're all very familiar with Cicely Saunders, as you said, but I think it provided a depth of the whole philosophy, and that was helpful. And I thought the case was great, the composite case, I guess. And I'll say, and I think it was mentioned toward the end, the term you used about the case, that applies to you. So I'm impressed with you. The phrase I think you used was, what if there's only one of me? And you were talking about the patient, but I don't know how you do what you do as I think Marty said, the sole palliative care provider. So just thank you, and I'll stop talking, but thanks so much.
Thank you.
I had a quick question. Was there any evidence-based research you found that helped support this whole team approach? Just because sometimes we work with a variety of providers who may or may not buy into that approach, and are very swayed by evidence-based research. So I was wondering in your preparation if you found anything that might gently nudge these other providers to consider this.
There is, and I can send that to Marty if he can link it back to this in some kind of way, or maybe link it when we post it to the YouTube.
Perfect.
Because
Thank you. That'd be great.
Wisconsin with the fast facts, they just put out something about total pain recently, and they have, of course, all the research. So I read very many of those, and there's actually a lot out there. But again, it does come down to which ones are kind of high quality, which ones are low quality, and things like that. But I think that those things only matter to the people that it matters to. Almost all research is helpful in some kind of way. So that's valuable. Thank you for asking that. I'll get that to Marty today.
Perfect.
Okay.
All right, Chandra. Thank you.
All right. Thank you. You guys have a great rest of your weekend.
You too. Bye.
Bye-bye.